Bună ziua, bine v-am regăsit. Vom continua cu următoarea demonstrație live. Este vorba despre cazul unui bărbat de 64 de ani care s-a prezentat pentru dureri epigastrice, melenă, arsuri retrosternale și regurgitații. Menționez faptul că pacientul este cunoscut cu ulcer duodenal în urmă cu 15 ani. Biologic, se decelează o anemie moderată. La gastroscopie s-a evidențiat un ulcer gastric atipic în regiunea peripilorică, care a fost biopsiat de 2 ori, dar de fiecare dată rezultatul histopatologic a fost negativ pentru cancer. S-a efectuat ecoendoscopie radială care a evidențiat la nivelul antrului periulceros o zonă de îngroșare parietală de până la 1,4-1,6 cm în unele secțiuni, cu îngroșarea evidentă a muscularei proprii, aceasta având o hipoecogenitate accentuată, modificare caracteristică în invazia neoplazică. S-a evidențiat de asemenea o îngroșare a submucoasei. Această pseudostratificare este caracteristică pentru linita plastică, care însă, în cazul acestui pacient, nu depășește stratul seros, îmi cer scuze. În cazul neoplasmului schiros, are loc dispariția tuturor straturilor. Din punct de vedere ecoendoscopic, avem în față un ulcer gastric T2, posibil malignizat, de fapt, de aceea este T2. Nu se evidențiază imagini de adenopatie satelită sau la nivel celiac, deci N0. Se pune întrebarea la acest pacient care este cea mai bună metodă de urmărire a leziunii. Rebiopsierea cu pensă jumbo sau pensa de biopsie folosită în colonoscopii sau o puncție fin aspirativă prin ecoendoscopie. Dau legătura domnului Dr.Harsha Vittal în sala de endoscopie care se va ocupa de acest caz. Vă mulțumesc!
Live.
Okay, we're back, and hope you had a good coffee break. Again, it's a real privilege to be back here in Cluj, and I am accompanied with Dr. Arya, and we're going to take a look at a patient who has a submucosal lesion in the stomach, and we're going to go down with the linear EUS scope, take a look at that, and then once we're there, we'll decide how we're going to get some tissue and try to determine a diagnosis. Okay. So we can go to the endoscopic view.
Bring him up more. There we go. Make it easier. Yeah.
That's it.
Can you just freeze the image and show also the public where the image is? So
Yeah, I think. Go ahead.
Well, I think, let's see there. This is the pointer. So this is the lesion right here. And I still feel that this is a mucosal lesion. I'm not convinced that this is a submucosal lesion. And I still believe that biopsying here with the forceps biopsies, getting deep tissue is going to be our best chance at a yield.
Yeah.
I think that's going to be far superior to trying to do FNA.
Of course.
As you can see, I'm struggling to maintain position as it is, and so I think
Plus
just
the needle offer you a small fragment.
that's
or
right. Well, I mean,
only
it's a
cells.
tissue sampling and subepithelial lesions is a complicated thing, and I think over the years have changed how I approach this. You know, initially what people would do is they would FNA, but if it's a relatively hypocellular lesion, you're not going to get a very good yield using FNA. So I've changed, and I think in this case is a little different than normal, but I think just tunnel biopsying, jumbo forceps biopsy is really the best way to approach this. What I have done in the past with much better results as far as tissue sampling is concerned is I've needle knifed the normal mucosa to access what is abnormal underneath it, taking jumbo forceps biopsies under that, and that's really improved my yields on these kinds of lesions. But I don't think that's necessary here. I think what we should do is just go back down with a regular upper scope and then proceed with tunnel biopsies and see if we can get a diagnosis that way. But I think we have a very good
strategy.
picture here. And I think what we will need is obviously a diagnosis, and then
Yes.
based on that, I imagine surgery is going to be in the near future here.
Yeah.
Do you agree?
Definitely.
Yeah, I think what I like to see is, here you can see that this is the superficial epithelial layer. This right here is the muscularis mucosa, and it looks like, we've got the balloon up against there, so maybe you might be compressing the epithelial layer, but clearly I think for what I'm seeing is the layer that's most abnormally appearing is the muscularis mucosa. What would you say? If you follow
Try
this,
to obtain another.
if you
You
follow
think
this,
so? You think this is muscularis mucosa here, or muscularis propria here?
no, that's muscularis mucosa.
Right.
Second layer. Then we get the submucosal layer. We're not seeing very well the submucosal layer here, and then, or this could be. That's one of the limitations here. I think this is muscularis propria here, which looks a little bit peculiar. But this is just one static image that we
Right,
have
so
here.
we can try this
The
again. then.
advantage of the ultrasound is the dynamic. Of
Right.
Yeah.
And I think
Compared
that's
with
I think that's why
sectional
a radial would probably
Yeah.
give us a very good image.
You just passed. Beautiful image.
So let's see here. So
Oh,
maybe
nice.
that
Yeah.
freeze
Nice.
that. Can we go to the big picture with that? No, that didn't work.
Yeah.
Oh yeah, there we
Oh,
go.
beautiful.
Okay.
Beautiful. Sometimes it takes take a step back.
That's
and look
right.
at
Let's step back. To
So I think that's as
It
good a picture
offers
as
you
we're going to get.
perspective.
it. Right.
You could see the landscape.
But again, and this is where we'll need some opinions here. I'm having a tough time trying to figure out which layers we're actually looking at here. I think everything is distorted.
So here,
The mucosa.
this is clearly the superficial
Right.
epithelium. Just
First layer.
below that would be your, muscularis mucosa,
Yeah.
the lamina propria, etc. And then we're not seeing a submucosal layer
That's right.
at all. We're not seeing what we should see is a submucosal layer, and then maybe I think here is muscularis propria,
Yeah.
which is a little irregular. Not a clear muscularis propria. For me, the concern here is I don't see a submucosal layer. Now the superficial biopsies that we did, the mucosal biopsies were negative for any kind of malignancy. So
Yeah.
and it's biopsied twice.
Yeah. Not by
So-
me, but. Yeah.
but,
no, not.
you
not
have
by
to-
me. I
we have to
only,
take that into
performed
consideration.
the ultrasound.
Right.
Yeah. The patient was referring to me.
So what would you like to choose between the jumbo
But-
biopsy of the mucosa?
Look, the muscularis propria. It's very thick.
See,
It's
that's
hypoechoic.
clearly muscularis propria,
Yeah.
I think. So
So what would you choose between a jumbo biopsy of the mucosa or with the knife and taking biopsies from the submucosa? Which of the two would you like to take?
I'm still debating in my
Debating.
head what
Yeah, yeah.
what the best approach to this would be.
Right.
I still think taking jumbo biopsy forceps and tunneling here would be the best option, and I think that's what I would do next.
Let's do it.
Let's do it.
Okay.
All right.
Okay.
Wow.
So we need a little.
Just trying to challenge me, huh? I understand. I understand.
We can trust this.
Okay, so here we're back, and we're looking at it with a therapeutic upper scope, and trying to get a decent image here. That's pretty good right there. So I think looking at it with an upper scope, I'm still, if I'd seen this initially, I would have been worried probably like everybody else that this was an adenocarcinoma. And the fact that the biopsies are negative is surprising, but not reassuring. And so tissue clearly is what we need. So hopefully we'll get a diagnosis this way.
So now when you're in your approach, are you going to just target the center of the lesion, the periphery? Is there any particular?
So in a normal sampling of a lesion like this, I think you would want to sample from various areas. But since we're going to try to do the tunnel technique, I would pick one area that I think is going to be the highest yield and go after that. At least that's how I would approach it. And I think in this case, since everybody's worried about malignancy, I think the ulcerated area, the central depression, is probably the money area. Open there. Close. Okay.
How did it feel on biopsy? Was there
Firm.
firmness?
It's
Yeah,
firm.
it's a firm lesion.
We have putting a large jar.
So do you know of any data that talks about how many of these you do before you feel comfortable you've done enough? Open there.
Once I see oil, I think I've tunneled pretty far.
There you go. If you see omental fat, you've gone too far.
You know you've got the tissue. And this is what happens, though. You know, obviously, as you biopsy, blood sort of obscures your area, so you're just really just trying to, I guess, go and maintain the same sort of angle and have the same approach with each successive biopsy.
Open there.
So you biopsy the same spot.
Exactly.
Same spot,
Exactly.
Deeper and
Close?
deeper and deeper.
Yes.
Biopsying the same spot deeper and deeper and deeper.
So
That's
this is
correct.
very similar to the way people used to tissue sample for biliary strictures. So if you remember the days, and when I trained, this is what we used to do. We would take forceps biopsies of malignant strictures of the bile duct, and we would stay in the same place and tunnel our way through, and the yields were actually quite good. It just took a lot of biopsies. We would take a mean of 10, and this is where I trained. They preferred doing that.